So let's start this webinar. And good morning from Melbourne, Australia, and also good afternoon from the United States. I know a lot of people attend this meeting. That's great. And then this meeting is a 2022 UIA Design for Health Student Competition webinar. This is the first webinar. We're going to organize another one if necessary. So the topic is that it's the next generation of stroke rehabilitation. We invited wonderful panel experts to discuss the key issues related to the stroke rehabilitation. So I'm going to introduce Dr. Aaron Davis, and then Dr. Davis is going to introduce the panelists. And Dr. Aaron Davis is the facilitation manager for the Neuroscience Optimized Virtual Environment Living Lab. It's NOVELL, so it's NOVELL Redesign. So he's a lecturer in architecture at the University of South Australia. And he has teaching and research focus on the process of designing healthcare environment, co-design and community engagement process, and interdisciplinary collaboration through living labs. So Aaron has expertise in social, cultural, and environmental sustainability, computer simulation, design process, community engagement, and design for health and well-being. And is recognized as the leader in development and delivery of highly engaging co-design approaches. So Dr. Davis, now the mic is yours.
Thank you very much, Lipeng. So before we get underway, in the spirit of reconciliation, NOVELL Redesign does acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We also acknowledge Indigenous communities globally on whose unceded lands global partner institutions are located. We pay our respect to elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples and global Indigenous peoples today. In particular, we pay respect to the elders and communities of the Kaurna and Wurundjeri nations on whose lands our panelists are sitting today. Now, before we jump into our panel discussion, I'd like to extend a very big welcome to everyone who's joining us live today, as well as all of those people who are watching our recording. It's fantastic to have all of you interested in this project, and we're really thrilled that you're excited not only by the competition, but also the opportunity to become involved in healthcare design and stroke rehabilitation design more generally. So my name is Dr. Aaron Davis, and I have the great pleasure of hosting our panel discussion today. Essentially, that means I don't really need to do anything because my panelists are going to share their pearls of wisdom. But as the introduction said, I'm a lecturer at the University of South Australia and an adjunct research fellow at the Florey Institute of Neuroscience and Mental Health, where I work as the facilitation manager on the NOVELL Redesign project that hopefully you've had an opportunity to learn a little bit about in preparing for this competition. Before I do introduce you to our panelists and ask them to make some opening statements for you, I'll briefly mention three things that you might hear either live today or in the recording that may be specific to Australia and may be different in your part of the world. So the first is that we will be using the term stroke survivor rather than stroke victim or stroke patient, as this is the preferred term of the Stroke Society of Australia. Secondly, when we're talking about rehabilitation environments, we are generally referring to subacute rehabilitation, which in Australia is typically attached to a major hospital, either on campus or remotely. And finally, when we say this word novel, it doesn't mean new. It means the Neuroscience Optimized Virtual Environments Living Lab, which is a bit of a mouthful, which is why we will refer to it as the NOVELL project. So without further ado, I'll introduce our panelists one by one and ask them to give a brief presentation before we jump into a more discursive format. So to begin, we have Anna Fox. Anna is an associate and architect at Silver Thomas Hanley, or STH. Anna has extensive experience in health planning and evidence-based design processes. Anna is passionate about creating better healthcare spaces that are not just functional, but which also encourage well-being and healing among their occupants. This passion, coupled with her knowledge of the user group consultation process and client liaison methods, allows her to develop efficient and innovative fit-out solutions that respond to clients' needs and requirements. Now, Anna, I believe, has prepared a short presentation on a couple of STH projects, so I'll hand over to her, allow her to share the screen so you can hear a little more about the work that Anna does. Thank you very much, Anna.
Great, thank you, Aaron. I'll just pop that up on the screen. So hopefully everyone can see that now. Yep, great. Okay. So as Aaron mentioned, I work at Silver Thomas Henley, or STH as we're more commonly known. We're a large architectural practice who specialise in healthcare, education and research facilities. So really anything broadly under the health umbrella, including large-scale acute hospitals, aged care facilities, mental health, laboratories, rehabilitation, community health. The practice has over 40 years of healthcare experience, and we have offices nationally and projects internationally. So we've got a vast portfolio of over 2,000 projects, so it was really hard to condense that into just a single slide, because we do a lot of different projects ranging in size and complexity across the full spectrum of architectural services. So what I mean by that is that we work right from master planning right through to construction, completion of the projects, and post-occupancy evaluation. Our client base is quite varied. We work with both those in the public and private sector. So we do work for government, and we also do work for private healthcare providers. So today I thought I would take the opportunity to show you some rehabilitation specific projects that STH has been involved in. So the first one is the Manukau Health Specialised Rehabilitation Centre in Manukau in New Zealand. This is a really exciting international collaboration with principal consultants, Jasmax Architects in New Zealand. And I must highlight that these images are courtesy of the Jasmax team. Currently it's in the design phase, and it's just a really interesting project. It's 60 beds and it's situated on the Manukau Super Clinic site. So it's a building within a larger health precinct. So there are a number of other projects also on the site as well, and there's future master plan proposal. So the location of the building in the first instance for this particular project was really important because it needed to consider an overall strategy for the site. And as part of the early phases of this project, we had visioning sessions with key stakeholders to develop a set of values and key principles to be addressed throughout the project. And these values and principles are often referred to throughout the design process to ensure that in all phases, we are addressing these items and responding to the feedback and the visioning of the wider team. So although it's a new building, it's bringing together services from 3 existing sites, which I guess has its own challenges as well, because the client working on 3 separate sites currently have different ways of working and managing their teams, and now they're coming together on in one project. So it will be a combination of stroke patients, spinal and general rehabilitation patients. There will also be outpatient and ambulatory facilities accommodated on the site as well. It features a therapy stair which connects the different levels of the building, living and dining spaces and informal interaction points along the corridors that I guess are really important in terms of allowing that interaction between both carers and their family members, but also their multidisciplinary care team. And it was a really important aim for this project that we were bringing together, bring rehabilitation to the forefront of the design and providing opportunities for rehabilitation to take place anywhere in the facility. Connection to nature was also really important, creating a sense of space, sense of place. The site itself has great opportunities for connection to nature, and we feel this is really important as part of the rehabilitation journey. There is a stream and wetlands adjacent, and the Jasmax landscape team are working through the inclusion of walking tracks and dedicated rest stops as well. There also is a strong focus on cultural engagement, and this has been and continues to be considered in all aspects of design, including dedicated space for family to be involved in the rehabilitation journey. And you can also see from some of the imagery that the materiality is carefully considered. There's a lot of timber to provide warmth and make it, I guess, the overall aim to make it a less clinical space. Oops, sorry. Jump ahead to the next one. So the next project is the Repatriation General Hospital, or REPAT, as we, I guess, have been commonly calling it. So this is in Adelaide in South Australia. This was an existing site that has been reimagined, excuse me, to be reactivated. So there's a number of challenges on this site, and it was a heritage overlay. So a number of the design elements we had to consider working with existing buildings and existing spaces. Again, this is a space for a number of different rehabilitation patients. There's a brain injury unit, a spinal cord unit, and a transition facility. So that includes spaces for people who might be preparing to transition back to their home, and also dementia patients as well. So there's also an outpatient component to this project. It includes a wellbeing centre, a sports gym, and a community hub, including a town square. The next one is the Acquired Brain Injury Unit, or ABI, as we've been calling it, in Caulfield in Victoria. This is a dedicated 42-bed inpatient facility. It's on a site with other health facilities as well, but it's I guess a standalone building within that health precinct. Again, it's for stroke patients, but also for brain trauma injury patients as well, and it has an outpatient rehabilitation service. The building is, I guess, derived around a courtyard design, and the buildings are centred around 4 courtyards, which each provide different rehabilitation opportunities. The bedroom design takes into consideration the requirements of patient movement, patients who might have mobility issues. So there's patient lifting tracks provided in the bedrooms, which assist with movement of patients from bedroom into adjoining en suites as well. And as you can see from some of the imagery, there's rehabilitation spaces such as gym and therapy spaces affording opportunities for group therapy as well as individualised therapy. So what I thought I'd include at the end is, I guess, some imagery of some casual touchdown points. We've had some discussions internally about the importance of collaboration as part of the rehabilitation journey. There's a lot of different people involved in terms of specialists, a lot of health professionals, family and carers are really important in the care. And so I guess this is just something we've been discussing internally. How can we provide opportunities within a facility that are, I guess, less formalised meeting rooms or interview spaces, but more casual touchdown zones that can accommodate conversations, allow people to get together in an informal way to discuss therapy and to discuss the rehabilitation journey, and keep people informed of what's happening, both for patients and carers and families, but also for the clinicians themselves, the interdisciplinary team. And then I thought I would finish on just some bedroom designs. These are not necessarily specific to the rehabilitation space, but I thought I would include them because I think what's important is that there's opportunities, especially in rehab where the length of stay might be quite long, that there's opportunities for personalisation within the bedroom spaces. And also you can see that there's space for family to be accommodated within the bedrooms as well. So I will finish there, Aaron, thank you. And I will just note that these images are single bedrooms. That's not to say that the bedrooms necessarily have to be single bedrooms, but I just wanted to show a select few. As I say, we've got a vast portfolio to select from, so I could only show you a select few at this point in time. So I'll stop sharing now. Thank you, Aaron. Thank you, everyone.
Thank you very much, Anna. And I'm sure if anybody has any questions or thoughts that they're wondering about what it's like to design rehab, or you've got any questions or challenges that you've been thinking about in responding to the design competition brief, please pop those into the chat so that we have a chance to get to those a little bit later on. But we will come back to Anna. I've got a couple of questions I'm burning to ask Anna as well. But before we do that, I'd like to introduce our second panelist, which is Brooke Parsons. Brooke is a stroke survivor and a consumer consultant who works across a wide range of projects. Now, a wide range of projects doesn't even cover how busy Brooke is. Brooke is a consumer consultant at the Florey Institute of Neuroscience and Mental Health for the Young Stroke Service, for the AVERT or Very Early Rehabilitation Trial, the AVERT Dose Trial and the PESTO Trial. I'm also very fortunate that Brooke has found time to be involved in the Novel project as well. Brooke describes herself as one day being very fit, healthy and invincible until that fateful day when she became a stroke survivor, collecting the tag disabled and envying the mobility of an elderly citizen. Since then, Brooke has been diagnosed with many other chronic health conditions, including postprandial reactive hypoglycemia, but still manages to be one of the most engaging and positive people I think I've ever met. For Brooke, growing up in a world of chaos where she has been chronically ill is a pretty tough gig. But despite this, she's a happy woman, although at times she does cry openly, the kind of tears that make people intensely chilled or very moved. At times, the world has seemed very sour to Brooke, like a musical note that has been flat when a crescendo was perhaps expected. She's had fleeting moments when she has doubted she'd ever be an independent person again, but she has pushed through to now live a very remarkably independent life. So Brooke, I wonder if you'd mind giving us a brief overview of your experience as a stroke survivor so that we can find out a little bit more about what it's like to be somebody who's going to be inhabiting these designs that everybody listening to this recording is going to be working on.
Fabulous. Thank you, Aaron, and thank you everybody for having me involved. Imagine being a pain in the butt teenager. I always call myself that, even in my early 40s. An A-grade student, highly involved in extracurricular activities. You could think of, I went from that to being restricted, scared, confused, surrounded by the contrived good cheer of well-meaning adults, of pots and pans in hospitals, looking up at white ceilings, and becoming to learn quickly that I was never going to be the person I once wished I was going to be. Instead, in a weird way, my life is perfect. Sure, I've had to learn to walk, talk, dress myself, feed myself, whilst growing up like my peers and joining in on all the fun that my peers were going through. I've spent almost the last 30 years in and out of hospitals, and as I've grown up, I've certainly been more aware of the corridors and the cracks in the grounds and every little spick and span of the hospitals, and I tend to sit there and criticize them. But I do know that I've undergone too many hospitalizations, countless tests, too many appointments to consider, and maybe that's a good thing because that's helped keep me going. If I was told 30 years ago that I would have 100 operations, I probably wouldn't have coped. Some of my admissions have been for rehab, more than some in fact, when I've had to relearn to walk, talk, and do it all. I've been in several hospitals, and as I get older, the longer I spend in them, I always come out saying, but what if I had unlimited funds? And what if I could just change one thing in the room? What if we just knocked out that wall? How much more room would we have? Being the only girl in my family has meant I'm not too good at sharing things either. So I do like my personal space, and I do like being in single rooms. And at times this has been challenged, and I've been forced to share a room with others. Hospital missions have varied from being overnight to several weeks or months, and I can guarantee most admissions have seen tears, and smiles and giggles as I learn new skills and ways to adapt them to my life now. I've seen a number of improvements in rehab and facilities over the last 30 years, such as access to hydro pools, accessibility into buildings, changing health needs as the populations grow, patients' expectations. Now, as an old bird in the health system, I know what I want. I will do what I think I need to do, but I think there's a bigger demand overall for the services. And I've seen advances in technology. So I think it would be fair to say I've lost a lot in my life: half a body, a wishful career, a life partner, family members. However, I'd like to think that just maybe one small thing I say to someone out in our community just might make a difference. And therefore, people like you and all that are listening, people that are smarter than me, can possibly turn a thought into reality. Thank you.
Thank you very much for sharing that short snippet of your life as well, Brooke. That's always moved me when we start to think about the fact that we are designing these spaces for real people who have a real experience in these spaces, rather than just the lines that we are putting on a page as we think through these design processes. So thank you. We do have I've prepared a couple of questions as well that I'm very interested to explore with you in a moment. But before we do that, I do have the pleasure of introducing, now I have to say almost doctor, because she's not quite yet, but very close, Michelle Shannon. Michelle is a neurological physiotherapist who submitted her PhD thesis in June this year under the supervision of Professor Julie Bernhardt at the Florey Institute of Neuroscience and Mental Health, Professor Marcus White, Professor of Architecture and Urban Design at Swinburne University, and Professor Marie Elf, Professor of Nursing at Dalarna University in Sweden. Michelle has now joined Associate Professor Nadine Andrews' group on the Peninsula Health funded Comprehensive Care Project as a project officer, and Professor Natasha Lannon's group as a research physiotherapist on falls after stroke randomized control trial at Alfred Health in Melbourne. Michelle's own research interests stem from her PhD, and she is continuing to build evidence as to whether interior hospital environments can be directly linked to better stroke recovery. Her research notes that animal models of stroke have helped us to identify that physical environments where opportunities for enhanced social, cognitive, and physical activity can be linked to better brain and behavioural recovery. She's used reviews, an observational study, and a virtual reality factorial study, which I hope she explains to us exactly what that is in a moment, to begin to explore how the physical design of hospitals might impact on human adults with brain injury. Her PhD research, somewhat uniquely in this area, did include the involvement of stroke survivor participants in a virtual reality study. So, Michelle, you've just completed your PhD, well, back in June, which was focused on the design of these rehabilitation environments, which I think everybody's going to be very interested in. Can you share a couple of the key findings of your work with us?
Thanks, Aaron, and thanks for having me on the panel. Yes, I'm a physiotherapist by background, and I've worked with people with a variety of neurological disorders for more than 20 years. So I have a lot of experience of working in lots of different types of buildings for health, hospitals, and at different stages of people's recovery after brain injury, from the ICU environment right through to subacute rehabilitation environments and into the community settings. My research in the PhD was really sought to examine how we can find ways and see the scientific rationale and understand more about the ways in which we can assess how different aspects of the interior building design can impact on people with brain injury and probably more specifically stroke. So there was a bit of a journey through my PhD. I needed to learn a lot as a very novice person to architecture, learn a lot about how people who are involved in design of spaces, in particular for the hospital settings, for people who fell into my target research population, which was likely to be stroke at that stage. But I knew that I had to go through the literature quite extensively in the beginning to be able to understand not just the ways in which people before me had sought to measure or explore how people responded to different aspects of the interior architectural design. So that is the different types of patient rooms, the layout of the corridors, whether it's a straight linear corridor or circular, the location of the nursing stations or the clinical care areas to the patient rooms, and the connection with the indoors and the outdoors. But narrowing it down through my inquiry, I began to focus from a fairly early stage on the patient room or the bedroom. So specifically the single patient room and the multi-patient room. So more than one bed in the patient room. So whether that would be a 2-bedroom design or a 4-bedroom, and obviously in the past, there's been many beds and many patients in multi-patient rooms. So I had to go digging basically to, and I used reviews for a lot of this to be able to uncover the different ways in which people before me, researchers and other designers and people in projects who have looked at measuring the responses of people who have been in hospital. And it's quite difficult because, as you can imagine, hospital design, not just a new building, but an existing design doesn't change, but there's a lot of factors at play within the hospital design. So when a person, never mind a patient or a stroke survivor themselves, is in, say, a hospital room, there's a lot of things going on in that room that could impact on the person, particularly if they're there for more than 24 hours. So you've got their exposure to what we would say sensory stimuli. So the fact that they're in a space where they've got other people around them, the location of other beds in the room, whether they can see the people opposite them or they're adjacent to them, what they're looking at around in the room. So the visual impact of the aesthetics of the materials that are around them, whether they can see the bathroom, where is the ensuite, so they can get to the toilet. Particularly if you're a person after stroke, you need to know where your bathroom is and how you can get there and how far it is, and how you're being distracted or you're positively getting an exposure to sensory stimuli that are visuals, or whether that's what's out the window. Is there a view? Is it a view that's worth looking at? Is it just a brick wall out there, or is there a view over the city or view of gardens? Do you have a line of sight to your to the people that you can see in the nursing station or other people in the room, what you're hearing and how you're experiencing that. And this is all impacting on people after stroke, depending on their stage of recovery. So in the beginning, what I came to understand a little bit when I was delving into it is that people often who are at the early stages of their stroke need rest and recuperation. They need to know where things are around them that they can access and look for help and seek assistance. And then as people move through their journey, they may need a bit more exposure to be able to get out and to move around. So that is quite challenging when you're trying to look for ways to capture that when you're recording or evaluating people's response to a change in the environment. So what I found was, yes, there's a lot of talk in the literature about single patient rooms and that they are better. So in my systematic review, I was able to sort of locate that there's a lot of variation in that. that people, yes, they might prefer them if you administer a certain measure on that, but people, if they're older or at a certain stage in their health journey, also find being in a single patient room very lonely. People who are in a single patient room in the literature seem to be more at risk of having a fall because they aren't seen. They're in that room and they're by themselves. But again, it depends a lot on what type of person, what recovery stage they're at in their journey. There are also a lot of theories and frameworks. When I did another type of review, I was able to discover that a lot of designers and researchers in health fields too are using different ways to frame asking the questions about how the environment that they're exposed to can impact on them. And there are more than 17 different types of theories out there, and they span many decades. And they cover a lot of different disciplines, from sociology to architecture to neurosciences. So I, in fact, used the theory of supportive design as the theory that I was working towards for my final study in my PhD. I also found, using an observational study where I just went into an existing health site within Melbourne, where I wanted to assess where people who had a neurological injury, and that included stroke, where were they located when they were in the hospital ward, what were they doing, who were they with, to see if there was any difference when you changed one ward environment to another. And importantly for that study, we needed to be able to make sure that the patients themselves, the type of conditions that they had, and the healthcare team looking after them were the same. So only the environment changed. And we found that even if you do what you think is a better design, and you provide more opportunities for experiences and communal spaces and different room types, that largely there wasn't a huge amount of difference, not as much as you would think, in the spread of the location of some of those patient locations. But in fact, the patients themselves spent a lot more time in the patient room. But we didn't explore whether it was the difference of the single versus the multi-patient room. And the final study was a virtual reality design study, and that was done with architect partners and was located at the Florey Institute. And this was a fantastic opportunity for us to be able to design a prototype comparison study where people who had stroke experienced going into a single patient room and a multi-patient room at the same time. And there were different iterations of both the single and the multi-patient room, where only one factor of the physical design elements within that changed. Because if you change too many things, you can't tell, particularly when you're applying a statistical examination of the design, then you can't reliably and accurately measure what the outcome is. So it's very important when you're using factorial design methods that you only use a small number of factors. So for that one, used the difference between the single and the multi-patient room, or the bedroom. The view through the window was either greenery outlook or an urban outlook. There was a wide or a narrow horizontal space, and there was nighttime noise. And interestingly, in all of those, overall, people preferred when we use measures that this is the challenge, to identify measures that we could use that would reliably inform what being in those different immersions of virtual reality could do to people, because it's not very easy to ask people to go through all these different types of designs, particularly when you've had a stroke diagnosis and you're recovering from stroke. So that's why we chose to do the virtual reality. In fact, overall, when we measured the people's emotional or affective response using a particular type of measure, we asked them to record while they were still in the virtual reality. They actually recorded that they were calm and relaxed in all of the room designs. So not just the single or not just the multi-patient, but there were slight variations according to the combination of different design features. So when there was more people present within the room space, for example, and the room was a multi-patient room, and they could experience the vision of seeing people around them, they were more heightened in their emotions. They had more negative emotional responses. And then at the end of all of that, I did some qualitative interviews. So I was able to explore very quickly after they had been spending time in the virtual reality. I was able to explore what their thoughts were about why they had those feelings. And I didn't do it so far away from the time when they did the experiment, because they may have been influenced by recall bias. And also I should mention as I finish that Brooke did get the opportunity to be involved in this at the beginning of the experiment, and we're very appreciative of her comments and feedback on that. So thank you.
Thank you very much, Michelle. And before I do return to some of our other panelists, I just wonder, you mentioned a couple of things that I'd love to unpack just a little bit further, because I think they could be quite useful. One of the challenges I always think when we are designing complex environments like this is knowing when we have found a good answer. And a lot of that comes down to how do we know what question to ask or what to check our design against. And a lot of the people entering this competition won't have the opportunity to wander around rehabilitation environments or speak to people with a lived experience. But you did mention the theory of supportive design, which potentially could be a good thing for people to investigate. Would you mind just explaining in brief what that theory kind of encompasses and what some of the key elements of that might look like in terms of checking a design against them?
Yes, that's a good question. So the theory of supportive design, the listeners probably maybe be familiar with the work of stress reduction theory that was described by Ulrich and has been used for many years when investigating from an environmental design point of view, how people, not specifically people in with the neurological disorder or stroke, but just how people in general react to their to the environment, to the physical design around them. And then that was extended later to healthcare facilities or impact on health. And then more recently, there has been others who have then started to investigate that more in the acute hospital environment. And in larger groups of people, thinking about how it is that the building itself or the exposure to the elements within the interior hospital design can actually lead to perceived stress. So how people report stress, not necessarily the same as having stress in a sort of biological sense, but that's certainly reporting it. So some of these researchers have looked at ways of sort of pulling apart the theory of supportive design to see what combination of the different elements within that had on the outcomes, which was stress in that case. So they looked at, for the theory of supportive design, they looked at positive distractions and I've just gone blank, sorry. they've got the, maybe we could come back to it and I'll get the exact wording, but they looked
Absolutely.
at 3 different aspects. Positive distractions was one, and what they wanted to be able to see was if the items that they gave the people exposure to, and they had to go out and sort of form some, did a preliminary study to be able to capture what it could be within the hospital environment. And they did that by actually just asking people. Unfortunately, they asked people who were just people out in the street. They didn't ask people who had direct experience of a health condition. And when they did another study, they asked people to look at floor plans and imagine that they had to be in hospital for an appendix surgery. So it's not quite the same. So you could imagine that the requirements for those types of people will be quite different than the experiences of the requirements of people who have a complex condition like stroke.
Absolutely. And I think that's a great segue to come back to Brooke and ask Brooke, in your lived experience of these environments, what do you think might be some of the misconceptions that people would have? I know going into this project a few years ago, I hadn't really thought about stroke rehabilitation environments ever. I'd never had a reason to. But what do you think are some of the misconceptions that people who don't have the experience of being in a rehabilitation environment may have about what these environments are actually like?
That's a really good question, Aaron. I think that, you know, because I've grown up in it, it's just something that I've always accepted. However, thinking back almost 30 years ago, and rehab was one-on-one, and it was very intensive, and it was 2 to 3 times a day, and it was over a long period of time. I think almost as our population has more demands on the health system and like our hospitals aren't maintaining their standards, if that makes sense. So there are cracks on the grounds and in the walls, and they're very old-fashioned. That I don't know if I've really answered your question, I'm afraid. It's like, I think, you know, I was in a private hospital here that's quite old, and you can tell it was quite old, in the bedding, just in everything. And then I went to a new building and into that rehab facility, and they nicknamed it the Princess Suite, which you would totally understand. And I was in a single room, but then I sat there and I was like doing little drawings because I was bored about how I could redesign that brand new room because there was wasted space. And yeah, it's very interesting.
No, that's great. And I mean, maybe we'll come back to Anna and ask you about, you know, we hope Brooke isn't talking about you as designing wasted space. But what do you think it is about rehab design that is so complex? What are some of those key things to look out for in rehab design?
Yeah, thanks, Aaron. And I guess in terms of the complexity, I think it comes in a number of layers, and it's not just about rehab specific, it's more about healthcare in general, is that I guess they're typically multiple departments and multiple services under the one roof. And so there's a lot of things happening, and they're complex in terms of their operation as well. They're a 24-hour facility, there's multiple different users, there's staff, there's patients, there's visitors, there's support staff, so there's that movement of linen and waste and food deliveries as well. So there's a lot to consider in terms of the flow of all of those things, and wanting to create, I guess, spaces that are, you know, this is a public space, this is a semi-public space, this is a private space, the different users and what spaces they can access, and how you provide that separation of flows in the staff-only space. It becomes very complicated, and often in SDH we note that cities are like little cities within cities. There's a lot of little movement going on, and I guess in terms of rehab as well, I guess what I mentioned in some of the projects that I referenced is there's a lot of different types of rehabilitation as well. There's not just the term rehabilitation encompasses a lot of different conditions that you might be responding to. There is stroke, there's brain injury, there's spinal cord injury, there's also some more common conditions such as arthritis and chronic pain and sports injuries. And then there's the complexity of the I guess, the people that might be attending. So patients might be ranging in age from pediatric patients right through to elderly patients, and they might need to be managed within the same care setting. So within that, you might need some separation of the patients themselves just due to their age, or it might be the cultural need. So I guess there's a lot to consider, which is why I guess it's so complicated, and needing to, I guess, step through and break it down and think about, well, who's using this facility? And perhaps it's also doing a bit of, journey mapping. If I'm a patient, what's my path of travel? How do I get into the building? How do I get to my room? Where can I go? Similar with a staff member, how do I arrive at the facility? What spaces do I need to access? And with those back of house flows as well. And I think both Michelle and Brooke have mentioned that patients might also be at different stages of their rehabilitation journey, and therefore they might have different needs and expectations. So I guess there's a need to understand the brief and understand the client base, and then respond with your design. And I think it's important to also note that, and we've sort of touched on this, that family have a really big impact on the recovery. So we need to be really mindful of the inclusion of spaces for families and carers within the design as well. And that might be, translate to dedicated spaces within the bedrooms, like the day beds, and dedicated space for families, overnight accommodation, interview rooms, meeting rooms, that sort of thing as well. So I guess I've said a lot, but there's really a lot to consider, and that's what makes them complex, but it also makes them really interesting.
Yeah, thanks for that, Anna. In the time that we do have left, I wonder if I could get each of you, we might start with Michelle, to reflect on what is one thing or one vision you would have for the future of rehab design that would be great to see, or one thing that you would love to see change in the way that we do design our rehabilitation facilities?
So yes, thank you. I would really love, because I totally acknowledge, I can see both sides, what the staff, what the patients, what the stroke survivors would want, and the clinicians. And also there's the other side where it's buildings, hospitals are very costly. And you build them and they're there for the next 50, 60 years. So I would really love if we're putting something innovative into our design, something that we think from the best evidence that we've got now, we could implement, but at the same time as we're implementing that, could we have something embedded in the fabric of that building space, that interior design, that could record how the building or the design features impact on the person, the stroke survivor in there. So we could get some longitudinal data that would either support or refute what we are putting into it, to allow it to be continuously building the evidence. That would be mine.
That's great. That's one of my pet projects, is to shift from a post-occupancy evaluation to an ongoing occupancy evaluation, to continue to evaluate how our healthcare facilities are performing. Now, Michelle, there was a question popped into the chat from Bettina that I'll give you a couple of minutes to think about while we go to perhaps Brooke. Would you like to think about the future? And if you had your unlimited resources or unlimited money, what's that key thing that you would change about rehabilitation design?
For me, Aaron, rehabilitation design would be, well, I try to do it every day, thinking beyond the stars and making what we think is impossible possible. And for me, that's about, at the moment, it's like making everything a smart device. So if a stroke survivor has ailments where they can't use one side of their body, they might be able to say, hey, Google, and then Google can follow through with the lights, or having a smart shower head, and just being mindful that as architects that, generally you've all got abled bodies. So it's hard for you guys to think outside the square, but that's where someone can say, well, hang on, you just go in and turn the shower on. But if I could set it to a timer, that would be way better. So it's thinking about things like that and then being able to transfer it into the homes of those people.
Excellent. Thank you for that. And apologies to anybody who just had their smart devices turn on at the mention of that key phrase. I know that always happens when somebody on TV mentions the S word. With mine in my house, my whole house goes haywire. Anna, if you had this amazing project where budgets aren't a consideration, what's that thing that you would do differently that perhaps some of the students might be able to pick up on in their designs?
Yeah, thanks, Aaron. I think it's a challenging question, and I think based on some discussions that we've had, I guess, with the novel redesign internally, and Brooke, with your feedback, I know we had a technology session this week, and one of the key themes that came up was empowerment, and I guess, Brooke, you're touching on that in terms of talking about the smart technology and I guess that level of independence. So I guess as an overarching theme, I'd like to see that we could create buildings that are more, I guess, enable that level of individualisation and that empowerment for stroke survivors and other rehab patients to be able to have that independence. And I guess some of it's technology based, but also I guess just in the way that the building is designed and the fabric, how can we accommodate some of these innovations? I think would be my broad overarching answer, to just really harness that empowerment.
Fabulous. Thank you very much for that, Anna. Now, Michelle, the question that was in the chat for those who are watching the recording was, what would be the most significant need of a patient in terms of design according to psychology? Have you got any thoughts on that one?
I'm not really understanding the question, because I don't know whether that means, is it from the psychologist point of view, the psychology researcher, or if the person means the psychological aspects of the design? Because I think really all design in regards to the interior building design of hospital will impact on human psychology. So that's why I chose measures in my final study related to affective or emotional responses. I also used choice preference, and then I used the qualitative interview methods because I needed to be able to delve more deeply into why they made the responses that they made. So I'm not entirely sure. I think there's a whole, I think there's if the person's alluding to forensic health or mental health, those facilities would bear, is there any solid psychological reason behind why mostly neutral colors used in the interior of hospitals or rehabilitation centers? Is there any solid psychological reason behind that? I think myself, I haven't investigated color specifically through the PhD, but anything that I've read or looked at, really there's no basis to that. I think it's just cost. Maybe in the past certain colors were believed, whether it was blue or it was orange, that they might have had a stimulating response on people when they spend time in there. But I think the studies that I've seen on that comparison didn't really hold up when they've applied more rigorous design. But I think mostly the studies that I've looked at have looked at healthcare workers in that. So yeah, it's one aspect, but I think there needs to be a bit more science behind it.
Absolutely. And you can see my little scientific experiment of my background. This project has a hot pink color scheme, so we're always feeling very enlivened by the colors that we are having. So we've got 3 or 4 minutes left before we do need to finish this up and let everybody get on with their days today. But I wonder if we can quickly go through Anna, then Brooke, and then back to you, Michelle, about any final closing remarks or advice you would give to the students undertaking this competition.
I think I would just start with saying don't be overwhelmed. I think like, yes, healthcare is complicated, but I think just try and, I guess, break it down in terms of thinking about who might be using the facility and the different users within the facility. And I guess just trying to make it as a calming environment as well. Often with healthcare, people might have been through a traumatic episode. There's a lot of stress that might be involved in that, and creating an environment where you can promote a sense of calm, but also a sense of well-being and hope and recovery, I think is important to consider for your design responses.
Excellent. Thank you for that, Anna. And Brooke, I think there's some issues going on with the technology of your camera, but I think your microphone is still with us. So have you got any final advice that you would give to our students?
Just keep going, keep believing, and we're all behind you, and reach out.
Perfect. Thank you very much for that, Brooke. I think Brooke is always inspirational in terms of making me feel empowered to just keep pushing through with these projects that we're working on. And Michelle?
I would probably just say for the students, from my own experience, just spend a good bit of time up front trying to work out exactly what your research question is. I think sometimes, because you obviously have a time and a deadline to get to the end and get something implemented and record and evaluate and all the rest of it, but just particularly for this topic where there can be so many factors and so many components involved, if whatever you've decided at the beginning and then you've sort of run with it, it could be too late to change. So spend a good bit of time at the beginning, invest the time to get the right research design for what you're wanting to do, and get people's feedback on that. Thank you.
Perfect. Well, thank you very much for that. And I will hand back to Zhipeng because that is the end of our hour together. But a very big thank you from me to each of our panelists. Thank you, Michelle. Thank you, Brooke. And thank you, Anna. I really do appreciate you giving up your time this morning, Australian time, or this evening, global time, to share just a small snippet of your expertise in this area. It's fantastic to have this cross-section from a clinical background, an architectural background, and a lived experience background to come together to give us a bit more of a taste of what this area of research can be as a part of the competition. So a big thank you from me, and please do make sure you are reaching out through the competition's email when you have any questions to clarify elements of the competition brief as well. Thank you very much, Zhipeng.
And thank you so much for the panelists. Thank you, Michelle and Aaron and Anna and Brooke. That's the really valuable, lectures for the students and all the competition participants. If they have additional questions related to your presentation, can they email me and send it to you? Maybe extra burden, but maybe they have more questions after, a good night's sleep in Texas. So yeah, thank you again. And there's additional questions over here. So maybe I can collect that and forward that to you. And a big thank you to all of the speakers, and have a good day in Australia, and have a good evening in Texas and all around the world. Thank you.
Thanks, everybody.
Bye now.
Thank you.
Everyone.
Bye.
Bye.
Bye.